Acute gastrointestinal hemorrhage. Welcome to today's podcast, where we discuss the main aspects of acute gastrointestinal hemorrhage. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the management of acute gastrointestinal hemorrhage. Pause the podcast after each question to attempt answer. Let's begin. Introduction question: what is the prevalence of gastrointestinal bleeding in the United States, and how commonly does it result in hospital admission? Answer: gastrointestinal bleeding is a frequent cause of hospital admission in the United States, with over 500,000 cases reported annually. Question: how is upper gastrointestinal bleeding defined, and what is its occurrence rate? Answer: upper gastrointestinal bleeding refers to bleeding originating from the esophagus, stomach, or duodenum, and occurs at a rate of 67 per 100,000 individuals. Question: how is lower gastrointestinal bleeding defined? Which population is most affected, and what is its incidence? Answer: lower gastrointestinal bleeding is defined as bleeding occurring beyond the ligament of Treitz, is more prevalent in males, and occurs at a rate of 36 per 100,000 individuals. Question: what are the most common causes of upper gastrointestinal bleeding? Answer: the most frequent causes of upper gastrointestinal bleeding include peptic ulcer disease, inflammation of the esophagus, inflammation of the stomach, and inflammation of the duodenum. Question: what are the less common causes of upper gastrointestinal bleeding? Answer: less frequent causes of upper gastrointestinal bleeding are varices, gastropathy related to portal hypertension, abnormal blood vessels, and the de la Foix lesion. Question: what are the rare causes of upper gastrointestinal bleeding? Answer: rare causes of upper gastrointestinal bleeding include abnormal connections between the aorta and the intestine, ingestion of foreign material, bleeding after surgery, tumors in the upper digestive tract, bleeding from the bile ducts, and bleeding from the pancreas. Question: what are the common symptoms associated with gastrointestinal bleeding? Answer: typical symptoms of gastrointestinal bleeding are vomiting blood or material resembling coffee grounds and the presence of black, tarry stools. Question: what is involved in the initial evaluation of a patient with suspected gastrointestinal bleeding? Answer: the initial evaluation should include a thorough medical history, a physical examination with attention to vital signs, and laboratory investigations to determine the severity of bleeding and guide further management. Question: what are the primary goals in the management of a patient with gastrointestinal bleeding? Answer: the main objectives are proper triage, ensuring the patient's circulatory stability, resuscitating as needed, initiating empiric medical treatment, and conducting diagnostic tests. Question: why are history and physical examination important in patients with suspected upper gastrointestinal bleeding? Answer: a detailed history and physical examination are essential to determine the best diagnostic approach and guide management in suspected cases of upper gastrointestinal bleeding. Question: what symptoms are indicative of upper gastrointestinal bleeding? Answer: symptoms such as black, tarry stools, blood detected in nasogastric lavage, and acute kidney injury related to reduced blood flow suggest upper gastrointestinal bleeding. Question: what symptom can exclude a diagnosis of upper gastrointestinal bleeding? Answer: the presence of blood clots in the stool is a finding that excludes upper gastrointestinal bleeding. Question: what does vomiting red blood or coffee ground material indicate about the source of bleeding? Answer: vomiting red blood or coffee ground material typically points to bleeding occurring above the ligament of Treitz. Question: what does the presence of black, tarry stools suggest about the origin of bleeding? Answer: black, tarry stools suggest bleeding that originates above the ligament of Treitz, but it can also arise from the mouth, throat, small intestine, or colon. Question: what does the passage of red or maroon blood in the stool usually indicate about the source of gastrointestinal bleeding? Answer: red or maroon blood in the stool is most often due to bleeding from the lower digestive tract, but can also be seen with severe upper gastrointestinal bleeding. Question: how does past medical history influence the evaluation of upper gastrointestinal bleeding? Answer: up to 60% of individuals with a history of upper gastrointestinal bleeding experience bleeding from the same lesion. Question: what comorbid conditions should be reviewed when evaluating a patient with gastrointestinal bleeding? Answer: it is important to assess for conditions like inflammation of the stomach, peptic ulcer disease, increased pressure in the portal vein, previous repair of an aortic aneurysm, abnormal blood vessels, cancer, and ulcers at surgical margins. Question: which medications increase the risk of gastrointestinal bleeding, and which can alter stool color? Answer: medications such as antiplatelet agents, medications that prevent blood clotting, selective serotonin reuptake inhibitors, calcium channel blockers, and aldosterone antagonists increase the risk of bleeding, while iron, licorice, charcoal, and bismuth can change the color of the stool. Question: what symptoms and signs may suggest severe bleeding in a patient with gastrointestinal hemorrhage? Answer: symptoms such as lightheadedness when standing, confusion, and cool, clammy extremities are indicative of significant bleeding. Question: which symptoms can help identify specific sources of gastrointestinal bleeding? Answer: abdominal pain, difficulty swallowing, vomiting, accumulation of fluid in the abdomen, yellowing of the skin and eyes, and unintended weight loss may indicate causes such as peptic ulcer disease, diseases of the esophagus, Mallory, Weiss tears, or malignancy. Question: what signs indicate hemodynamic instability and potentially life-threatening bleeding? Answer: orthostatic hypotension, confusion, and clammy extremities can signal instability of the circulatory system and life-threatening bleeding. Question: how is physical examination used to assess blood loss in gastrointestinal bleeding? Answer: physical examination is vital for evaluating the stability of the circulatory system and estimating the amount of blood lost. Question: how do vital signs change with increasing percentages of blood loss? Answer: blood loss between 15 to 30% results in a widened pulse pressure, reduced urine production, and increased heart rate. Loss between 30 to 40% causes low blood pressure, increased heart rate, confusion, and reduced urine output. Loss above 40% leads to low blood pressure, increased heart rate and breathing rate, lethargy, and almost no urine output. Question: can patients with minor blood loss have normal vital signs? Answer: yes. Those with less than 15% blood volume loss, up to 750 milliliters, may exhibit normal vital signs. Question: what laboratory tests are recommended for evaluating acute upper gastrointestinal bleeding? Answer: recommended laboratory tests include a complete blood count, serum chemistry studies, blood typing and screening, liver function tests, and studies of blood clotting ability. Question: how does hemoglobin concentration change over time in acute gastrointestinal bleeding, and how should it be monitored? Answer: hemoglobin levels are initially similar to baseline but decrease over time and should be monitored every 2 to 8 hours depending on the severity of bleeding. Question: what does an elevated ratio of blood urea nitrogen to creatinine suggest in the context of gastrointestinal bleeding? Answer: an increased ratio of blood urea nitrogen to creatinine indicates a higher likelihood that the bleeding source is in the upper digestive tract, especially when values are 30 to 1 or 100 to 1. Question: what are the common causes of lower gastrointestinal bleeding? Answer: the most common causes include diverticular disease, abnormal blood vessels, and inflammatory bowel disease. Question: what other conditions may cause lower gastrointestinal bleeding? Answer: other causes include infectious inflammation of the colon, reduced blood supply to the colon, cancer of the colon, hemorrhoids, tears at the anal opening, varices in the rectum, damage from radiation, and complications following surgery. Question: what is the typical symptom of lower gastrointestinal bleeding? Answer: the usual symptom is the passage of maroon or bright red blood or blood clots through the rectum. Question: how often does lower gastrointestinal bleeding resolve on its own? Answer: lower gastrointestinal bleeding stops spontaneously in 80 to 85% of patients. Question: what is the mortality rate associated with lower gastrointestinal bleeding? Answer: the mortality rate ranges from 2 to 4%. Question: what are the main causes of acute lower gastrointestinal bleeding? Answer: acute lower gastrointestinal bleeding may result from anatomical abnormalities, vascular disorders, inflammation, neoplastic processes, and interventions for treatment. Question: what steps are involved in the initial management of acute lower gastrointestinal bleeding? Answer: initial management includes establishing intravenous access, triage, supportive care, and ruling out bleeding from the upper digestive tract. Question: what aspects of patient history are important for evaluating acute lower gastrointestinal bleeding? Answer: it is crucial to review past medical history, current medications, and any accompanying symptoms to identify the underlying cause. Diagnosis and management of gastrointestinal bleeding. Question: what is the recommended approach for managing hemodynamic instability in patients with gastrointestinal bleeding? Answer. Adequate peripheral vascular access should be established using large intravenous catheters or a central line. Question. When should endotracheal intubation be considered in patients with gastrointestinal bleeding? Answer. Elective intubation should be considered in patients who are actively vomiting blood or who have altered breathing or mental status to facilitate endoscopy and reduce the risk of aspiration. Question. What is the impact of elective endotracheal intubation on outcomes in critically ill patients with gastrointestinal bleeding? Answer. Elective endotracheal intubation may be associated with poorer outcomes in critically ill patients. Question. What are the criteria for admission to the intensive care unit for patients with gastrointestinal bleeding? Answer. Patients who are unstable or have active bleeding should be admitted to the intensive care unit. Question. When should fluid resuscitation be initiated in patients with gastrointestinal bleeding? Answer. Fluid resuscitation should begin immediately in patients with unstable circulatory status or ongoing bleeding. Question. On what basis should transfusion decisions be made in gastrointestinal bleeding? Answer. Transfusion should be guided by circulatory parameters, rate of bleeding, estimated blood loss, and whether bleeding has been controlled, rather than solely by hemoglobin concentration. Question. What is the recommended timing for blood transfusion in patients with gastrointestinal bleeding? Answer. Immediate transfusion is indicated for patients with active bleeding, while transfusion may be delayed for those who are stable. Question. What is the preferred transfusion strategy for stable patients with gastrointestinal bleeding? Answer. A restrictive approach, transfusing only when hemoglobin is less than 7 grams per deciliter, is recommended for stable patients. Question. Why is close monitoring important for stable patients with gastrointestinal bleeding? Answer. Close monitoring is essential, as the need for transfusion may develop later even in initially stable patients. Question. What is the role of acid suppression therapy in upper gastrointestinal bleeding? Answer. Proton pump inhibitors are crucial in the management of upper gastrointestinal bleeding. Question. How should proton pump inhibitors be administered to patients with upper gastrointestinal bleeding? Answer. Intravenous proton pump inhibitors given every 12 hours are preferred for stable patients, and continuous infusion is also an option. Question. What are the benefits of using proton pump inhibitors in upper gastrointestinal bleeding? Answer. Proton pump inhibitors reduce the risk of recurrent bleeding, shorten hospital stays, and decrease the need for blood transfusions. Question. What is the function of erythromycin in the management of acute upper gastrointestinal bleeding? Answer. Erythromycin is used to improve visualization of the stomach during endoscopy by promoting gastric emptying. Question. How is erythromycin administered before endoscopy, and what monitoring is required? Answer. Erythromycin is given as a 250 mg intravenous dose over 20 to 30 minutes, with endoscopy performed 20 to 90 minutes later. Monitoring for prolongation of the QT interval and drug interactions is necessary. Question. What benefits does erythromycin offer in patients with upper gastrointestinal bleeding? Answer. Erythromycin improves visualization during endoscopy, reduces the need for repeat procedures, and shortens hospital stays. Question. What medications are used to treat variceal bleeding, and what additional benefit may they offer? Answer. Somatostatin and terlipressin are used to treat bleeding from varices and may also reduce the risk of bleeding from other sources. Question. How is octreotide administered for variceal bleeding? Answer. Octreotide is given as a 50 mg intravenous bolus, followed by a continuous infusion at 50 mg per hour. Question. Is octreotide recommended for non-variceal upper gastrointestinal bleeding? Answer. Octreotide is not routinely recommended, but may be used as adjunctive therapy when endoscopy is unavailable or to stabilize patients before definitive treatment. Question. What is the role of prophylactic antibiotics in patients with cirrhosis and gastrointestinal bleeding? Answer. Prophylactic antibiotics may reduce the risk of infections and mortality in hospitalized patients with cirrhosis and gastrointestinal bleeding. Question. What is the risk of infection in hospitalized patients with cirrhosis and gastrointestinal bleeding? Answer. Up to 20% have bacterial infections on admission, and up to 50% develop infections during their hospital stay. Question. What benefits do prophylactic antibiotics provide for hospitalized patients with esophageal variceal bleeding? Answer. Prophylactic antibiotics may decrease mortality and reduce the risk of recurrent bleeding. Question: what is the primary management approach for upper gastrointestinal bleeding, and when is surgical or radiological consultation indicated? Answer: management is primarily medical and begins with upper endoscopy. Surgical or interventional radiology consultation is considered if endoscopic treatment fails, the patient is at high risk for rebleeding, or if complications develop. Question: is placement of a nasogastric tube recommended in patients with upper gastrointestinal bleeding? Answer: routine placement of a nasogastric tube is not recommended, as it does not improve clinical outcomes. Early placement may be considered in unclear cases or to facilitate endoscopy. Question: how can nasogastric tube lavage assist in the management of upper gastrointestinal bleeding? Answer: nasogastric tube lavage can be used to clear the stomach for endoscopy, but may not be positive if bleeding has stopped or occurs beyond a closed pylorus. Question: what is the preferred diagnostic tool for acute upper gastrointestinal bleeding? Answer: upper endoscopy is the preferred method for diagnosing acute upper gastrointestinal bleeding. Question: when should endoscopy be performed in patients with suspected upper gastrointestinal bleeding? Answer: early endoscopy within 24 hours is recommended for most patients, and within 12 hours for suspected bleeding from varices. Question: what can endoscopy reveal in patients with gastrointestinal bleeding, and how are findings in peptic ulcers classified? Answer: endoscopy can identify bleeding lesions and offer therapeutic interventions. Findings in peptic ulcers are classified using the modified Forrest classification. Question: what are the categories of findings in peptic ulcer bleeding according to the modified Forrest classification? Answer: categories include spurting hemorrhage, Class IA, oozing hemorrhage, Class IB, a visible vessel without bleeding, Class IIA, an adherent clot, Class IIB, a flat pigmented spot, Class IIC, and a clean ulcer base, Class 3. Question: how does the endoscopic appearance of lesions influence further management? Answer: the endoscopic appearance helps determine whether additional management beyond endoscopic therapy is required. Question: when is a second endoscopy indicated in gastrointestinal bleeding? Answer: a second endoscopy may be necessary if blood obscures the source of bleeding, although routine repeat procedures are not recommended. Question: what diagnostic tests are available for acute upper gastrointestinal bleeding besides endoscopy? Answer: additional tests include computed tomography angiography, traditional angiography, deep small bowel endoscopy, and rarely, intraoperative enteroscopy. Question: are barium studies indicated for upper gastrointestinal bleeding? Answer: barium studies are contraindicated in the setting of acute upper gastrointestinal bleeding. Question: what is the role of wireless capsule endoscopy in suspected upper gastrointestinal bleeding? Answer: wireless capsule endoscopy can assist in patient triage and help identify those who may benefit from early endoscopy. Surgical management of upper gastrointestinal bleeding. Question: what determines the need for surgical management in upper gastrointestinal bleeding? Answer: surgical management depends on the source of bleeding and the failure of non-surgical treatments. Question: what is the dual intent of managing upper gastrointestinal bleeding caused by malignancies? Answer: management aims to control bleeding and perform an oncologic procedure. Question: is surgical intervention commonly required for Mallory-Weiss tears? Answer: surgical intervention is rarely needed for Mallory-Weiss tears. Question: what surgical procedure is used for Mallory-Weiss tears? Answer: laparoscopic or open oversewing of the tear under endoscopic guidance is performed. Question: what are the outcomes of surgical management for Mallory-Weiss tears? Answer: surgical management yields excellent results. Question: what is the recommended rescue therapy for patients with bleeding from esophageal varices who have failed medical or endoscopic management? Answer: emergent transjugular intrahepatic portosystemic shunt or surgical creation of a portocaval shunt is recommended. Question: why is a transjugular intrahepatic portosystemic shunt preferred over surgery in patients with cirrhosis and acute variceal hemorrhage? Answer: transjugular intrahepatic portosystemic shunt is preferred due to high operative mortality in patients with cirrhosis, although acute variceal hemorrhage carries significant mortality regardless of treatment. Question: what surgical management options are available for upper gastrointestinal bleeding? Answer: options include shunting and non-shunting procedures, such as devascularization of the esophagus and stomach, transection of the esophagus, and removal of the spleen. Question: When is emergency surgery considered for upper gastrointestinal bleeding? Answer. Emergency surgery is rarely the first choice due to high mortality in severe cases, but may be life-saving when other options are unsuccessful. Question. When is elective surgery considered in upper gastrointestinal bleeding? Answer. Elective surgery is considered when shunt procedures are unsuitable because of extensive vein thrombosis and other treatments have failed. Question. What are the survival rates following surgery for upper gastrointestinal bleeding? Answer. Perioperative mortality is 12.7%, and 5-year survival rates range from 58 to 93%, depending on liver function classification. Question. How are shunt types classified in the surgical management of gastrointestinal bleeding? Answer. Shunts are classified as total or portosystemic, and as non-selective or selective. Question. What is involved in a total shunt procedure? Answer. Total shunt procedures involve end-to-side or side-to-side connections between the portal vein and the inferior vena cava. Question. What is a partial shunt procedure, and what is its benefit? Answer. A partial shunt procedure, such as a portacaval anastomosis, reduces pressure in the portal vein while maintaining forward flow. Question. What are some types of selective shunt procedures? Answer. Selective shunt types include distal sphenorenal shunt and small diameter H-graft shunt. Question. What are some non-selective shunt types? Answer. Non-selective shunt types include portacaval shunt, mesocaval shunt, central sphenorenal shunt, and large diameter H-graft shunt. Question. What material is used for shunt grafts in surgical procedures? Answer. Polytetrafluoroethylene reinforced grafts are used for shunt procedures. Question. What advantages do selective shunt procedures offer? Answer. Selective shunts are superior in controlling bleeding, maintaining portal vein flow, and preserving liver function. Question. What benefits do selective shunt procedures provide regarding postoperative complications and survival? Answer. Selective shunt procedures decrease the risk of postoperative brain dysfunction and improve overall survival, particularly in patients without alcohol-related liver disease. Question. What does the literature indicate about the effectiveness of selective shunt procedures compared to other options? Answer. Selective shunts are found to be more effective than other procedures. Question. What is the primary goal of surgical intervention in upper gastrointestinal bleeding? Answer. The primary goal is to control hemorrhage, followed by definitive treatment of the ulcer. Question. What is considered the best treatment for ulcers causing upper gastrointestinal bleeding? Answer. Excision of the ulcer and repair of the stomach is regarded as the best treatment. Question. What techniques are used for excising ulcers during surgical management? Answer. Techniques include wedge resection, removal of the lower part of the stomach, and opening the front part of the stomach, depending on the location of the ulcer. Question. What is the standard surgical approach for duodenal ulcers causing bleeding? Answer. The standard approach consists of making a lengthwise incision in the front of the duodenum, ligating the bleeding vessel, often the gastroduodenal artery, and performing a pyloroplasty. Question. What additional surgical procedure may be performed to reduce the risk of recurrent ulceration? Answer. Truncal vagotomy may be performed if the patient is stable to lower the risk of recurrent ulcer formation. Question. How does gastric resection compare to standard approaches in surgical management of bleeding ulcers? Answer. Gastric resection is more extensive, results in lower rates of recurrent bleeding, but is associated with higher rates of complications. Non-surgical management of lower gastrointestinal bleeding. Question. What are the main goals in the management of lower gastrointestinal bleeding? Answer. The goals are to identify the source of bleeding, assess its severity, triage patients, provide supportive care, and initiate resuscitation. Question. How is the diagnostic and treatment approach determined in lower gastrointestinal bleeding? Answer. The approach depends on the source of bleeding, which may be identified during colonoscopy or angiography, and treatment is tailored to the specific lesion type. Question. What additional diagnostic procedures are reserved for patients with severe, ongoing lower gastrointestinal bleeding? Answer. Radionuclide imaging, computed tomography angiography, and mesenteric angiography are reserved for severe, persistent bleeding. Question. What is the preferred diagnostic test for stable patients with lower gastrointestinal bleeding? Answer. Colonoscopy is preferred as it allows for accurate localization of the bleeding site, biopsy, and therapeutic intervention. Question. What considerations are necessary for performing a high-quality colonoscopy in lower gastrointestinal bleeding? Answer: adequate bowel preparation and anesthesia are required, but these carry risks of further bleeding, perforation, and post-procedural complications. Question: which patients may not require immediate colonoscopy for lower gastrointestinal bleeding? Answer: patients with a history of presumed or confirmed diverticular bleeding, modest blood loss that resolves on its own, and a recent high-quality colonoscopy within the past 12 months may not need immediate colonoscopy. Question: what is the likelihood of identifying a bleeding source during colonoscopy in lower gastrointestinal bleeding? Answer: a definitive or potential source is visualized in 45 to 90% of patients. Question: is it common to identify more than one potential bleeding site during colonoscopy? Answer: yes. Identification of multiple potential bleeding sites is common. Question: when should colonoscopy be performed in patients with lower gastrointestinal bleeding? Answer: colonoscopy should be performed on the next available basis after adequate preparation, as timing within 24 to 96 hours does not affect identification of bleeding stigmata. Question: what is the role of imaging modalities in the diagnosis of gastrointestinal bleeding? Answer: imaging can help diagnose bleeding throughout the digestive tract, including the small intestine. Question: can treatment of the bleeding site be performed during angiography? Answer: yes. Treatment can be attempted during angiography. Question: when is computed tomography angiography used in patients with gastrointestinal bleeding? Answer: computed tomography angiography is used to select patients with active bleeding for subsequent angiography or to localize the source before surgery. Question: what is the initial diagnostic test of choice for patients with ongoing, significant bleeding per rectum? Answer: computed tomography angiography is the initial test of choice for patients with ongoing, significant bleeding per rectum. Question: what are the advantages of computed tomography angiography in gastrointestinal bleeding? Answer: it is widely available, rapid, minimally invasive, provides anatomical detail, and can detect bleeding at a rate of 0.3 to 0.5 milliliters per minute. Question: what are the limitations of computed tomography angiography in gastrointestinal bleeding? Answer: it does not offer therapeutic capability, exposes patients to radiation, requires intravenous contrast, and only detects active bleeding. Question: when is angiography indicated in gastrointestinal bleeding? Answer: angiography is used in patients with severe bleeding and circulatory instability when endoscopy is not feasible. Question: how is the timing of computed tomography angiography and angiography coordinated in gastrointestinal bleeding? Answer: computed tomography angiography is commonly used to localize bleeding before angiography, and angiographies performed within 90 minutes of a positive computed tomography angiography are more likely to detect bleeding. Question: what vessels are typically examined during angiography for gastrointestinal bleeding? Answer: the superior mesenteric artery is examined first, followed by the inferior mesenteric and celiac arteries if the initial study is negative. Question: what advantages does angiography offer in gastrointestinal bleeding? Answer: angiography requires no bowel preparation, provides accurate anatomical localization, and allows for therapeutic intervention. Question: what is the role of transcatheter embolization in the management of gastrointestinal bleeding? Answer: transcatheter embolization is used to control bleeding and has replaced other temporary interventions. Question: how does superselective embolization benefit patients with gastrointestinal bleeding? Answer: superselective embolization lowers the risk of bowel infarction and is feasible in 98% of patients with active bleeding. Question: what is the sensitivity of radionuclide scanning in detecting gastrointestinal bleeding? Answer: radionuclide scanning detects bleeding at rates as low as 0.1 to 0.5 milliliters per minute, making it the most sensitive radiographic test. Question: what limitation does radionuclide scanning have in localizing gastrointestinal bleeding? Answer: it can only localize bleeding to a general abdominal area, with accuracy rates varying widely. Question: what is the recommended follow-up procedure after a positive radionuclide scan for gastrointestinal bleeding? Answer: angiography should be performed promptly to precisely locate the bleeding source. Question: what additional diagnostic evaluations should be considered in patients with severe, ongoing bleeding? Answer: upper endoscopy or push enteroscopy should be considered. as up to 15% may have bleeding from the upper digestive tract. Question: how can small bowel bleeding sites be evaluated? Answer: capsule endoscopy and deep small bowel endoscopy are used to evaluate bleeding sites in the small intestine. Question: what are provocative challenges, and when are they used in gastrointestinal bleeding diagnosis? Answer: provocative challenges involve the use of vasodilators, medications that prevent blood clotting, and thrombolytics to aid diagnosis. They are rarely used and only by expert centers due to significant risk. Surgical treatment of lower gastrointestinal bleeding. Question: what determines the need for surgical treatment of lower gastrointestinal bleeding? Answer: surgical treatment depends on the source of bleeding and can often be controlled during colonoscopy or angiography. Question: why is preoperative localization important in surgical management of lower gastrointestinal bleeding? Answer: preoperative localization is essential to reduce the risks of morbidity and mortality associated with removal of part of the colon. Question: how is recurrent lower gastrointestinal bleeding managed? Answer: recurrent bleeding requires repeat colonoscopy with endoscopic hemostasis if indicated. Question: what are the indications for surgical intervention in lower gastrointestinal bleeding? Answer: indications include persistent circulatory instability with active bleeding, ongoing or recurrent bleeding, or transfusion of more than 4 units of blood in 24 hours with active or recurrent bleeding. Question: what factors influence the choice of surgical procedure in lower gastrointestinal bleeding? Answer: the choice depends on the patient's circulatory stability, overall health, existing medical conditions, and preoperative localization of the bleeding source. Question: what surgical procedure options are available for lower gastrointestinal bleeding? Answer: options include segmental removal of the bowel for localized bleeding in stable patients, removal of nearly the entire colon for unknown sources, and II stage or single stage connection of the small intestine to the rectum for unstable patients with widespread disease. Outcomes in gastrointestinal bleeding. Question: what is the in-hospital mortality rate for patients with gastrointestinal bleeding? Answer: the in-hospital mortality rate is 10% during hospitalization and up to 1 month after admission. Question: what is the long-term mortality rate following admission for gastrointestinal bleeding? Answer: the long-term mortality rate approaches 37% at 3 years after admission. Question: what factors are associated with increased mortality in patients with gastrointestinal bleeding? Answer: mortality is higher in females, individuals with multiple hospitalizations, those with malignancies, and those with bleeding from varices. Question: what is the in-hospital mortality rate for lower gastrointestinal bleeding, and what is the usual cause of death? Answer: the in-hospital mortality rate is less than 4%, with most deaths resulting from existing medical conditions rather than the bleeding itself. Question: what are the risk factors for mortality in patients with lower gastrointestinal bleeding? Answer: risk factors include advanced age, existing medical conditions, secondary bleeding, blood clotting disorders, low blood volume, need for transfusion, and male sex. Question: what are examples of benign causes of lower gastrointestinal bleeding associated with low mortality risk? Answer: hemorrhoids, tears at the anal opening, and polyps in the colon are benign causes with low risk of death. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.